Life is a sparkling diamond with countless hidden gems. It is best for those who enjoy it, difficult for those who compare it, but worse for those who criticize it. So what matters in the end is our attitude and thoughts which actually define it. Welcome, ladies and gentlemen, to Dr. Tapaswini's Corner. And that's me, and I work as a head and neck cancer surgeon at the Fortis Hospital, Delhi. Today's episode will highlight numerous issues pertaining to ovarian cancer, also described as a silent killer. To discuss in depth on its various aspects, we have with us today an exceptionally talented and renowned gynae-oncosurgeon from Bangalore, Dr. Somashekhar. You are the Chairman Oncology and Head of the Department of Surgical and Gynae-Oncology at the Manipal Cancer Center, Bangalore. You also hold the position of Director Robotic Surgery Fellowship and Breast Oncoplasty Surgery Fellowship at the Manipal University. Your work has been extensively centered around the management of advanced gynecological cancers, complex cytoreductive surgeries, different forms of chemotherapy techniques, HIPEC, PIPAC, intraperitoneal chemotherapy have all been advocated, promoted, and practiced under your able pioneership. With more than 300 publications in the national and international journal, your research skills have been widely recognized across the globe. Times Healthcare Achievers Award, Millennium Gold Medal Award, and the prestigious Dr. D.D. Patel Gold Medal have been additional feathers in your cap. Welcome, Dr. Somashekhar, to the show. It's a great pleasure and honor to have you here today for the program.
Thank you very much, Dr. Tapaswini. It's my pleasure to be here. You know that me clinicians, you and me, you're also a surgical oncologist like me. We have two facets. One part of our satisfaction is treating our patient and making them all right. But the second one is actually, sharing and connecting with the public and like-minded people like you. So yes. It's my pleasure and honor to be here and wonderful.
Lovely, sir, lovely. How are the overall statistics of ovarian cancer when we compare developing vis-a-vis the developed nations, one, and also ovarian cancers with respect to the other cancers?
Absolutely. There is some unique way when we compare the East versus West, developed versus developing countries. So the things change a lot. Like, for example, there are some cancer which are for upper strata. The breast cancer, the endometrial cancer, they actually are more, in Western world. And cervical cancer and other cancers are more common with us. But unfortunately, the ovarian cancer is not so. It is called silent killer. We know that. Normally in Asian countries and African countries, it is usually 3 per 100,000. In Western world, like Africa, North America, it is 8 per 100,000. So in India, we have 8.6 per lakh ovarian cancer, as per the National Cancer Registry Program we have. And it is postulated that in India, there is 1 out of 78 women will get an ovarian cancer. 1 out of 108 women will die of ovarian cancer. So unfortunately, even though this is not in a very high incidence, the mortality is quite high.
Okay. So is there a particular age group that we see these diseases?
Absolutely. Again, there is some unique phenomenon to cancers in India, you know that. Most of the cancers in India are a decade early, like, like the breast cancer and the ovarian cancer. Typically in Western world, the peak of ovarian cancer is between 55 years to 65 years. Somewhere around 63 is the median. But in India, the peak is 45 to 54. What do we notice? It is 1 decade early. So our young women during their productive life, unfortunately, are hit with the tsunami of ovarian cancer. So in India, it is a decade early. 10% of ovarian cancer in India, unfortunately, happen less than 32 years. So in India, the peak is 45 to 54. Western world is 60 to 64. And we have very large group of young women with ovarian cancer.
So, as you said, that there is an age group which affects the young, but we also get to hear ovarian cancers in teenagers. So, what is this picture, and how is it, and how do these little girls present vis-a-vis the ovarian cancer in the older women?
Absolutely. There is a bimodal distribution we have for this ovarian cancer.
Mm-hmm.
While the elderly at perimenopause and menopause end up with epithelial ovarian cancer,
Right.
the young group, who are just completed the pediatric group. So in age between 6 to 25, 35, actually there is another unique type of ovarian cancer which we call germ cell ovarian tumor. Their gonads, ovaries are just matured, they're growing up. So there is a specific group of ovary cancer called germ cell tumor, which happens in that population. And the most important thing is 45% of them actually come with pain abdomen. Remember, ovarian cancer is called silent killer. Mm-hmm. The reason is they don't produce any symptom. Straight away they come in third stage. But the pediatric and young age germ cell actually present with pain abdomen. But the beauty is they're highly curable, highly chemosensitive, and we can always do a fertility preserving cancer. Wow. So the myth like young woman will not have cancer, no. If you have something, please always get it treated with your doctor. It could be ovarian cancer, but treatable.
Okay. So let's tell our listeners as to what are the factors which increase the risk of ovarian cancer.
The main basis we need to understand is what is the cyclical change that happens in ovary. Mm-hmm. There is a surface on the ovary. Every month a ovary follicle is produced. It is broken. Ovary is, egg is produced, and then it repairs. So there is a constant wear and tear and damage. This is what is one of the risk factor, which means if somebody doesn't have enough pregnancy, parity, if they have multiple children, then they have lactation. For an year period is stopped, ovulation is stopped. So that is a protective phenomenon. So increased age is a risk factor. Obesity, which is very common problem. Now we are also moving towards, unfortunately, westernization of lifestyle. So obesity is a risk factor. Nulliparous, a lady who has no children or probably not more than one, is at more risk because their ovary, number of menstrual cycle and ovulation in a woman's time, if it is longer, then it is a risk factor. Women after menopause, if they taken hormone replacement therapy, HRT, is a risk factor. In addition to all this, there is a genetic factor called as genetic gene hereditary breast cancer syndrome. So these are the factors which we need to keep in mind.
Okay. How about smoking and some dietary issues which could be there in the causation?
In general, if you ask me, does smoking directly impart epithelial ovarian cancer? The answer is no, unlike cervical cancer.
Okay.
But there is one rare variety of ovarian cancer which we call mucinous tumor. Okay. These tumors are, chemo resistant. They don't respond well to chemo. This particular group, a causation, smoking as an etiology is found. Obesity and diet is directly linked. Okay. You are obese, you have got 6 to 8% more chance of ovarian cancer.
So you also elucidated on issues that this could be having a strong family history. So how important is to do a genetic mutation analysis and genetic counseling of our patients?
Absolutely. That's a very essential component. For the listeners, I want to say two things. There is something called as familial cancer syndromes and hereditary. So we carry these genes from our mother, grandmother. The most common is a BRCA, BRCA1, BRCA2 genes.
Right.
This is present in 15% of population in India. If you randomly check 100 women, 15 of them would harbor this.
Okay.
So it is found that 18% of ovarian cancer women would have this gene. If they have BRCA1, 50% of them are going to develop ovarian cancer in their lifetime. Very high number. If you have BRCA2 genes, 20% of you will actually develop ovarian cancer. This is one of the reasons there is a big landmark study from Australian group, which told Every woman who has a high risk for ovarian cancer should have a genetic testing done. Genetic counselor are available. So it is very important to do this genetic mutation test. Now they're fairly available, even though not very economical, they're fairly available. They cost between 10 to 20,000, and most of the centers do offer.
Right, right. Good, great. But tell us, how important is screening? So if we have to really diagnose and detect our patients early, what would be the role of screening in the population?
This is something very irony. We
Mm-hmm.
doctors, oncologists, always tend to blame the patient. We say, why did you come late?
Yes.
Why are you not screening for yourself? But there are some unique cancer in the body where screening changes, like breast cancer, cervical, oral cancer. Unfortunately, ovarian cancer, in spite of being an aggressive cancer, silent killer, in a normal population who are not high-risk genetic carrier,
Okay.
screening has not, unfortunately, shown to identify cancers early. Which means, it is quite sad for us, because this is like lung cancer. We know it is morbid. So like lung cancer, ovarian cancer for common public, screening has not made an impact. However, if there is a family history of breast ovary cancer, you fall into high group. This group should undergo a regular screening at an young age, which should be started at an young age.
Okay, right. But Dr. Som, tell us, there are certain preventive measures also. Do we advocate some sort of surgery, which we call as prophylactic surgery, to prevent this cancer?
Absolutely. Taking this cue from the screening, does it make an impact in ovarian cancer? There were two large studies. One was done in UK, which looked at in common population, prophylactic treatment and surgery and screening. Did it make an impact? That didn't make an impact in the survival outcome. However, if you are identified with BRCA1 or 2 gene or RAD mutation gene, or you have a hereditary family syndrome, in that group, there is a type of surgery called prophylactic risk reduction surgery.
Okay.
They save life. Now in ovarian cancer, what is this surgery? Simple daycare laparoscopic tubes and ovary removal. The new concept is, even though ovary cancer is in ovary, it comes from the edge of the tube. So removing the tube, medical term, we call that salpingo-oophorectomy. It's a small daycare procedure done with 5 millimeter keyhole. This is a risk reduction surgery. In high risk group, it saves and prevents 99% of the time ovarian cancer developing.
Okay. So when we are talking about prophylactic surgery, so this is doing surgery before the cancer appears.
Absolutely.
Right? Okay.
So when we say risk reduction prophylactic surgery, it is not a patient, but a normal person walking among us as of today, not having a disease, but before seeing medical technology, they have high chance of cancer later.
Correct, correct. So when we say that ovarian cancer is a silent killer, can you just elaborate a little bit more on it?
Okay. See, it is something like that. We say a third sense. Suppose a tsunami is coming, okay, the weather changes, birds fly and sky. So every bad thing that happens in the world, there is some subtle change nature has given.
Right.
So if you are going to be hit with a big disease like ovarian cancer, we expect maybe I don't feel like eating, or I have a change of voice, or you think that, okay, there is a lump or a bump, your body well, or there is an alteration in the bowel movements, or there is a change in the monthly period cycle. Unfortunately, ovaries are deep hidden organ in our tummy, covered by a lot of other structures, and they are not attached to anything major. So until they come to stage 3, they don't throw any symptom. No pain, no loss of food, no lumps bump felt. So the day you feel a bloating sensation and tummy bloats up with water, already it is stage 3. That's why ovarian cancer is called as a silent killer, because even a doctor who themselves have this cancer, in spite of all the knowledge examination, they identified 2/3 of them come only in stage 3. So the moment you are at stage 3, today in the world, you go to America, London, India, anywhere, stage 3 ovarian cancer, only 10% 5-year survival. Means out of 100 women, 90 are dead at 5 years in spite of the best treatment in the world, which is very sad. So we have a disease where 2/3 come in advanced 3rd stage. There are no sign symptom to identify before. Screening in normal population doesn't help. And at stage 3C, 10% only are alive at 10. So if you don't call this a silent killer, what more is a silent killer?
So how do we investigate them?
Number 1, bimanual digital pelvic examination, number 1. Number 2, we do transvaginal Doppler ultrasound every 6 months.
Okay.
And there is a tumor marker called the CA125. So it's a triad of 3. This done at every 3 to 6 months interval, identify the cancer early. This can be used only in genetic mutation patients or high risk groups.
Okay. So looking into the treatment, how do we proceed from here? Once investigated, what sort of a treatment do we offer our patients?
In oncology, there are 3 major treatments: surgical treatment, chemotherapy treatment, radiation.
Right.
Ovary cancer is quite unique. Even though it is highly radiosensitive, we don't usually use radiotherapy. So the mainstay of treatment in ovarian cancer is surgery and chemo. This is highly chemosensitive. It melts, it melts like ice melts to a sun or a butter. Highly sensitive to platinum-based chemo. So now the most important thing, uniqueness about ovary cancer is, many cancer, the cause of death is spread outside the organ, like brain, liver, lung, bone, vital organs. But ovarian cancer rarely spread outside the tummy. It is confined inside the peritoneal cavity. So treatment has 3 parts. A good surgery, which we call cytoreductive surgery, to remove all the visible cancer. And then chemotherapy, which is given in the blood to prevent recurrence. And local treatment into the tummy, which is called as intraperitoneal chemo. Because here what happens in ovarian cancer is 2/3 of them keeps coming back inside the abdominal tummy cavity. So if you give chemo in the blood, it will not go adequately into the peritoneal cavity. Concentration is low. So we do something called as intraperitoneal port chemo or hyperthermic intraperitoneal chemo, where heat with chemo pump during the surgery are used. So essentially, surgery with intraperitoneal chemo with heat or hypic and IV chemo. There is another arm. If they come with very advanced disease, there is a immunotherapy and also special Parp inhibitor tablet, but they're used in mutated, genetic case of BRCA and advanced disease.
Okay. Dr. Som, you are a great gynae oncosurgeon and of course a surgical oncologist, oncosurgeon. Tell us how scientific and technological advancements have added to your surgical armamentarium.
Ovarian cancer treatment is my passion. Across the globe, people know that maximum research work, publication and work is mine. And I have a tertiary referral center which come across the world for ovarian cancer. I've done about roughly 6,000 cases. When I look back, my treatment from the year 2000 to 2005, 10 and beyond, initially surgery was the only option available for us with chemo. Unfortunately, 10% women only are alive with a good surgery, IV chemo. Then in the second phase, the technological advancement happened where there is a special ports which we implant on the skin below the tummy. Chemo is given through that. It increased the survival by 10% extra. So we went to 30% survival. Then the further technological advancement that happened is from special dialysis like pump machines from Italy and US, where we put these thermocouples into the abdomen, 41.5 degree heated chemo we pump. What is seen to human eye, I remove. Microscopic cells are killed. This is called HIPEC. This advancement is last 10 years. Now we also have a keyhole robotic minimal access advancement. If somebody comes very early where it has not spread anywhere, or you want to look at a staging laparoscopy, keyhole advancement too happened. Simultaneously, medical management advancement happened called as a Parp inhibitor tablets and anti-angiogenic factor. So I have to say that last 7-10 years, technological advancement in surgical field in terms of high-tech, minimal invasive robotic, and medical oncology do happen. And now the 10% survival has gone down up to 45 to 55% cure. Almost we have doubled, but still we are not at 70 to 80% cure like in other good cancers.
Okay. So the robotic surgery that you talked about, so has it really scored over the conventional surgeries that we were doing in the past?
Yeah. Now, in other gynae onco surgeries, like the cervical cancer or the uterus endometrial cancer, they have been extensively used. Now, ovarian cancer is a double-edged sword. Rarely a woman comes in early cancer, and the success of ovary cancer is removing it intact without breaching the covering of the ovary. If we breach or rupture during surgery, chance of cure becomes half. If chemo is not required, chemo is compulsory. That's why people are little cautious while using robotic surgery in ovary. We evaluate putting a camera. Can I remove it intact, put it in a bag, seal it so it doesn't spill? So in those cases, we do that. Advanced surgery, even though we use robot for uterus cancer, cervix cancer, in ovary, we are little judicious and cautious.
Okay. So we were talking about treatment. Is the treatment of patients who have genetic mutation any different from patients who do not carry the same?
Yeah. Now, if they carry genetic mutation, BRCA1, BRCA2, this is such an irony. Everywhere we say, if I have something mutation abnormality, it is not good. But if they have genetic mutation, it is good for the patient, not good for the family. Why? I'll give an example.
Okay.
For that patient, that particular ovarian cancer is more sensitive to platinum chemo. So they have better response if you treat with platinum. HIPEC, the hyperthermic intraperitoneal chemo, is most useful in BRCA1, BRCA2.
Okay.
Then there is a special tablet which is called as Parp Inhibitors, olaparib, rucaparib. These tablets act only if you are BRCA1, BRCA2. So for patient, platinum chemo acts well, HIPEC acts well, and there is special 2 tablets. But the flip side is, if a patient carries, their siblings, their children have 25% chance of having that gene, in turn having breast and ovary cancer. So it is like, happy news. You don't know, you should be happy for you or be unhappy for your sibling and children.
True, true, true. We were talking about the overall survival. So can you just elaborate a little bit? How is the survival with respect to the various stages?
There are a lot of prognostic factors for cancer. Like age. Age, I can't decide when I get cancer. Nobody wants age. And higher grade, that is not with me. God decides. Or, what type of ovary cancer I have, epithelial, non-epithelial, I can't decide on that. What stage? Nobody wants a cancer. If given a choice, I want in stage 0. All these are non-modifiable factors not in my hand. True. But no treatment in the history of solid tumors in humankind is dependent on one doctor, that is ovarian cancer. The surgery person who does decides the whole cure rate. Surgery done by a person who is a qualified surgical oncologist in gynae onco. Results are one of the best than operated by general gynecologist or general surgeon. There is a term called as optimal cytoreduction, which means, I always say this, ovary cancer surgery takes 5 to 6 hours. This is not a surgery you should do if you have some other work meeting, you have to go for a movie in the evening, or you want to take your family. Don't do this. Before you close the abdomen, the last skin stitch you put, we have to ask one conscious question to myself. Did I remove all the cancer in this lady? If I leave one nodule more than 10 millimeter inside the abdomen, that lady is never going to be cured. No matter what $1 million chemo I give, medicine I give. So this is the term called as optimal cytoreduction. The surgeon doing the surgery, surgeon's effort, optimal cytoreduction translates to cure. Now, if you have done the best surgery, survival is minimum 3 to 4 years. If you're left 10 millimeter, 0% 3-year survival. In addition to this best surgery, if you have not done intraperitoneal chemo or HIPEC, the cure rates are half.
Okay.
If they don't receive 6-cycle chemo, their survival is half.
There are many who would be in the last stages of their disease. What do we have to offer them?
Remember, we oncologists, we philosophically accept two parts. First, we don't play God.
True.
Equally important to identify early cancers, equally important to treat adequately, advanced yet curable, but to be modest and be a good human being with the right head on our shoulder to accept there is a group of patients, we can't cure them. So pain, palliation, rehabilitation is the most important humane approach of every oncologist, sometimes much more than aggressive treatment, making them stay in hospital for their whatever life left, giving complication, depriving them of quality time they can spend with their family, loved ones, go enjoy nature, listen to music. So we have certain stage 4 non-curable ovarian cancer. Very important to be a good human being first than an aggressive surgeon, to accept, discuss with that patient. I may not be able to cure you, keep you 5 years alive, but let's concentrate on the best quality of life for remaining months or year God has given. I'll make it pain-free. You are the boss who dictate what treatment you want. I'll keep you pain-free. I'll make you eat well, and I'll give the best pain, palliation, rehabilitation, and holistic other part of cancer treatment, not necessarily chemosurgery. Give that 5 months or 10 months of fantastic life, which is equivalent to 100 years for them. Music therapy, yoga therapy, loved ones to be there, and painting, and the patient would do what they want. And they would dictate their treatment, and we just follow and carry them as a best friend and a human being rather than an aggressive doctor.
Wonderful, wonderful. Dr. Som, now that we are coming to the end of this program, what is the concluding message that you would love to give to all our listeners?
You started off with a beautiful line, what is life? All of us have only one life. Nobody is immortal. The way we live that life is more important than how long we live. And remember, now during this COVID pandemic, people know the value of health. No amount of money, $1 million can compensate that. We always used to read health is wealth, health is wealth. Now we really know the value of it. So take care of your health and body, not for yourself, for your loved one. If you go, who suffer? Not you, the people around you, the loved ones. Take care of your health, diet. And remember, in cancer, don't wait to be a patient. Don't wait for signs and symptoms. First signs and symptoms in ovarian cancer is advanced. So all cancer like breast cancer, oral and cervical, we say once a year do a cancer screening package. You don't have to be patient. People never do that. How many do it? So the best message I want to give you is don't look at, okay, this month is purple ribbon ovarian cancer month. This is pink ribbon breast cancer. This is yellow ribbon. This is lymphoma. That month I remember and forget. No. On your loved one, when you get up today, mother, wife, sister, husband, brother, on their birthday morning, once you wish them happy birthday, ask your question. Did I gift my mother, sister, wife, brother cancer screening package? Once a year to be done, nearest hospital to your home, few hundreds, like a mammogram or an oral examination or just simple oral cavity examination, a pap smear. And then your loved one will gift you for you to be alive for your loved ones. So the message I want to give to your audience through this. Thank you.
Wonderful, wonderful. I couldn't have asked anything more.
Thank you.
Yeah, beautifully spelled out. And I think the listeners would have got the hang of what ovarian cancer is all about. Lovely, Dr. Som, and it was wonderful having you today here for the program.
My gratitude to you, and it's my pleasure and honor. Thank you.
Thank you so much. Life changes so quickly. There are moments which make us happy, but there would be some painted moments with sadness. But one has to fight through the dark days to earn the best of one's life. As someone said, no matter howsoever dark it may get, the sun will rise again. Thank you once again. Thank you, Dr. Som, and thank you to all the listeners. See you next week in another episode. Till then, goodbye.